Welcome back to the Deep Dive, where we take complex, high-stakes information and give you the essential knowledge required to truly be well-informed. Today, we are putting on our surgical scrubs and stepping into the deep technical end of abdominal surgery. We're focusing on a procedure that is often called the ultimate test of an HPB surgeon, the hepaticojejuostomy, or HepJej.
And this deep dive is absolutely necessary because the hepaticojejuostomy, it isn't just a connector piece. It is the definitive, delicate gold standard for biliary enteric reconstruction. If you want to understand the surgical artistry, the difference between a permanent functional bypass and a near certain long-term stricture, you have to understand the micro-precision required in that hilar anastomosis.
So our mission today is to move your understanding of HepJej from just a textbook entry to a fully visualized operational strategy. We're going to be unpacking the critical knowledge, the historical lessons learned in the OR, and those vital technical secrets used by top hepatopancreatobiliary or HPB surgical teams worldwide.
Exactly. And we must, right at the very outset, establish the academic gravitas of the material we're synthesizing for you today. This deep dive is based on academic data and, just as importantly, clinical experience provided by Dr. Senthil Kumaran. He's an associate professor of surgery at AIIMS Nagpur in India.
That's the foundation we need. And Dr. Kumaran's trajectory, it's impressive. It includes his MBBS from Jammu Pondicherry and his MS in general surgery from PGIMER, Chandigarh. And crucially, that foundation led to over 15 years of post-MS surgical experience.
And his operative exposure, which is really the wellspring of this insight, is immense. It stems directly from his high-volume residency at PGIMER and his current practice at AIIMS Nagpur. Importantly, his training focused heavily on hands-on participation under leading institutional experts, including Professor Leeleshwar Kaman and Professor Bhupinder Mehra and their colleagues. This is experience forged in high-demand, high-volume centers.
Right. And what we learned about the specific institutional approach is fascinating. It speaks directly to prioritizing patient outcomes over, say, procedural speed. They typically favor an initial, highly precise laparoscopic dissection. They use that to define the complex, often scarred anatomy, and then follow it with an open reconstruction.
And that decision to transition to open for the anastomosis itself, that's a crucial acknowledgement. It says that when the stakes are this high, and the tissue is this delicate, pure precision and perfect visualization, which you get with the open approach, well, that often yields the most consistently good long-term outcomes for this specific repair. We are talking about drawing on real-world, high-volume, and deeply considered surgical strategies here.
Okay, so let's unpack the initial setup. Before we get to the how, we have to understand the why.
Yeah.
For the listener who might only vaguely know the term, what are the primary critical clinical scenarios that mandate this highly technical surgical bypass? Why is a hepaticojejuostomy necessary in the first place?
The necessity arises anytime the natural plumbing system for bile flow, so the common bile duct, is either irreparably damaged, needs to be removed because of some pathology, or it just has to be permanently bypassed. It's an essential rerouting exercise at its core.
Give us the list of indications, maybe detail the context for the learner.
Okay. The most recognized setting is following complex oncological resections, primarily the pancreaticoduodenectomy, which most people know as the Whipple procedure. For context, when a surgeon removes the head of the pancreas for cancer, they also have to remove the distal bile duct. This leaves the remaining common hepatic duct, just sort of hanging. It requires a permanent functional reconstruction.
So the Whipple procedure itself inherently necessitates an HepJej. What about non-cancerous scenarios?
The second major and often most challenging category is the repair of complex bile duct injuries. These are frequently iatrogenic, so unintentionally caused, often after a laparoscopic cholecystectomy. This leads to benign strictures high up near the liver hilum. HepJej is the gold standard repair for these severe injuries, often what we call a high biliary stricture, a bismuth type 3 or 4.
Wow. So you're saying that dealing with the aftermath of damage often requires a reconstruction that's even more complex than the original reason for the surgery.
Oh, absolutely. Beyond those two major pillars, we see it post-resection for hilar cholangiocarcinoma. Those are tumors right where the ducts enter the liver, so extensive duct segments get removed. It's also used after a choledochal cyst excision in both kids and adults, and critically, in cases of a failed prior biliary reconstruction. If a previous repair fails and scars down, creating a stricture, that highly technical redo surgery almost always requires a new, robust HepJej.
That immediately underscores the extreme pressure this anastomosis is under. It's not just connecting two pipes. It's connecting a highly delicate duct to the intestine and managing a flow of caustic, enzyme-rich bile. If it fails, as you mentioned, the consequences are severe, bile leaks leading to peritonitis and sepsis, and then chronic failure, which leads to repeated infections, cholangitis, and irreversible liver damage, secondary biliary cirrhosis.
The stakes could not be higher. And this is what leads us to the historical lessons. The procedure, it wasn't always this robust. In the early 20th century, before we had these foundational principles, surgeons were fighting against incredibly high rates of strictures and leaks.
So what were they missing in those early days? Why did those initial direct anastomoses fail so dramatically?
They lacked two critical pieces of knowledge. First, they just didn't fully appreciate the extremely delicate and segmental blood supply to the extrahepatic bile duct. So using crushing clamps or aggressive cautery meant they were sewing non-viable ischemic tissue, which of course inevitably broke down. Second, they hadn't mastered the hydraulics. Direct connections led to high pressures and chronic reflux of intestinal contents right up into the delicate biliary tree.
So what was the breakthrough? What moved this procedure from being a high-risk gamble to a standard, reliable operation?
The breakthrough came in two parts, largely in the mid-20th century. The first architectural leap was the introduction of the Roux-en-Y principle. This didn't just connect the bowel, it created an isolated, blind-ended jejunal limb, usually 40–50 centimeters long. It was specifically designed to receive bile flow without the pressure of food mixing or reflux from the main digestive stream. This was an absolute game changer for preventing ascending contamination.
So it essentially created a clean, dedicated drainage channel, a one-way street for the bile.
Exactly. And the second, concurrent realization, involved the technical execution itself. The non-negotiable concepts of creating a tension-free anastomosis and achieving perfect mucosa-to-mucosa alignment. These became the surgical mandate.
Creating a perfectly aligned, tension-free connection deep in the abdomen involving delicate tissues under low magnification. I mean, that sounds like a massive logistical challenge.
It is the definition of precision surgery. And this brings us directly to the foundational rules that govern modern practice, the Blumgart principles. If the Roux-en-Y provided the architecture, you could say Blumgart codified the building standards for this delicate connection.
Okay, let's detail these because they sound like they represent the difference between short-term survival and long-term patency. What are the non-negotiable Blumgart tenets?
He emphasized three critical interrelated elements. First, the anastomosis must be wide. You should think of it not as a straw, but as a river channel. If the diameter is too small, flow resistance is high, sludge builds up, and stricture is pretty much guaranteed. We strive for the widest possible opening. Second, the anastomosis must be performed on well-vascularized tissue. Both the jejunal limb and the hepatic duct edge have to be pink and bleeding gently. That signifies optimal oxygenation.
Right. No ischemia allowed. What is the third, the technical principle?
The third is the execution, the use of gentle handling and critically interrupted fine sutures. This is a rejection of older, more aggressive techniques. The goal is a repair so gentle, so meticulously aligned, that the body accepts it as natural. And HJ today is really viewed as a high-fidelity physiological reconstruction.
So we've defined the why and the historical evolution that taught us that tension and ischemia kill the repair. But that tension risk begins the moment we touch the most dangerous area, the hilum. And this brings us to the core anatomy.
Yes, and this section is really dedicated to paranoia because in the hilum, safety is predicated on absolute anatomical knowledge. We're working in a tight, confined space, often called the Hiller plate, where all these vital structures converge.
So walk us through the cornerstones of safety. Start with the positional relationship of the main ducts and vessels.
Okay, the cornerstone of safety is understanding the relationships of the three primary structures: the common hepatic duct, the portal vein, and the hepatic artery. The common hepatic duct occupies a consistently vulnerable location. It lies anterior to the portal vein and usually to the right of the main hepatic artery proper. This means that separating the bile duct from the portal vein requires delicate, sharp dissection that is completely unforgiving.
It sounds like the duct is just draped right over the biggest blood highway in the area. Now let's get to the critical decision point. The choice between the right hepatic duct, RHD, and the left hepatic duct, LHD, for the anastomosis. Why is there such a strong surgical preference?
This is a decision based purely on geometry and access, and it is almost universally mandated. The left hepatic duct, or LHD, is the preferred target when it's surgically accessible. We need to compare their geographical characteristics to really understand why.
Let's look at the challenging anatomy first. The RHD. What's the problem there?
The right hepatic duct poses multiple challenges. First, it has a significantly shorter extrahepatic length, which makes it difficult to mobilize without creating tension. It's also typically positioned more vertically and often lies deep and posterior in the operative field. Most crucially, because of that short vertical orientation, the surgeon has a very limited and precarious surface area to make the necessary incision, the ductotomy. This just results in a smaller potential anastomosis.
So it's short, it's deep, and it's difficult to work on.
Precisely. Now, contrast that with the left hepatic duct, LHD. The LHD runs a distinctly more horizontal, slightly superior course. It also tends to have a longer segment that is extrahepatic, meaning it's physically farther away from the unforgiving, fixed structures of the liver itself.
That horizontal orientation seems key. Does it offer a mechanical advantage?
A huge advantage. Its orientation provides the surgeon with safer, more accessible exposure. And because of its length and geometry, it allows for a wider, more generous ductotomy. A wider ductotomy translates directly into a wider, less restricted, and more easily sutured anastomosis. And that significantly reduces the risk of a late stricture.
So the surgical principle is mandated by physics. When possible, use the LHD because its location and length make the procedure technically safer and more reliable for long-term patency. It gives the surgeon more room to maneuver and more surface to connect.
That is the essential takeaway. However, neither duct is safe if the surgeon neglects the single greatest vascular pitfall in the hilum, the aberrant right hepatic artery, or ARHA.
Here is the surprise anatomy that can cause catastrophes. What is the nature of this anomaly and its specific danger?
The ARHA is a common anatomical variation where the right hepatic artery arises unexpectedly, often from the superior mesenteric artery, the SMA, rather than from the standard hepatic artery proper. The danger isn't its origin, but its course. It typically runs in extremely close proximity to, or sometimes directly posterior to, the bile duct itself.
So during dissection, especially in a field that's clouded by inflammation or scar tissue, a surgeon might unintentionally clip, ligate, or injure this vessel, mistaking it for fibrous tissue or a minor branch.
That is the fear that governs every moment of dissection in the hilum. The operational rule learned from decades of experience is therefore, the surgeon must always assume an aberrant RHA exists until proven otherwise. You approach that dissection with what surgeons call a healthy paranoia.
And why is injuring the ARHA such a technical disaster, specifically for the HJ?
Because the blood supply to the bile duct, particularly the supraduodenal portion, is often tenuous. It runs in small vessels at the 3 and 9 o'clock positions. If the ARHA is the primary or sole supply to the remnant right lobe, and if the surgeon injures it while mobilizing or trimming the duct, you have guaranteed bile duct ischemia.
And as we learned from Blumgard's principles, ischemic tissue is destined to break down. That guarantees anastomotic failure, a leak, and a late dense stricture.
Exactly. You might have saved 10 minutes on the dissection, but you just cost the patient years of reoperations and liver morbidity. It is the ultimate surgical trap.
How are modern HPV teams mitigating this risk, especially in those challenging redo surgeries where scar tissue makes everything look the same?
Well, technology is now assisting the surgical eye. We rely heavily on indocyanine green, or ICG, fluorescence. ICG is a dye that's injected preoperatively. Under specific near-infrared light, it fluoresces intensely.
So ICG is injected. What does the surgeon actually see?
Well, when it comes to the biliary system, if you flush the ducts, the bile lights up green, defining the often obscured anatomy. But more importantly, for the ARHA risk, when it flows through the blood vessels, it highlights the arterial tree in real time.
So it's like a surgical heat map. The vascular structures, including an aberrantly located artery, suddenly glow against the background tissue.
That is an excellent analogy. It turns hidden structures visible. This is especially vital during the initial laparoscopic phase, or when navigating the dense scarred tissue you see in redo surgery. It allows the surgeon to positively identify and protect that critical aberrant vessel before any injury can occur.
Okay, so we've confirmed the anatomy, identified the LHD as the target, and protected the vascular supply, particularly the ARHA. Now we shift into the preparation phase, getting the two tubes ready for that perfect connection. This is like the checklist phase of preparing the raw material.
Absolutely. The preparation defines the outcome. If you sew two unhealthy edges together, the repair will fail, regardless of how perfectly you tie the knots.
Let's start with duct preparation. What constitutes a healthy duct edge?
The primary goal is viability. The duct has to be trimmed to ensure that the mucosa is healthy, pink, and gently viable. It should show signs of perfusion. This often means sacrificing a millimeter or two of the duct to get back to unscarred, well-perfused tissue. We are looking for that good, pink, bleeding edge. That's the guarantee of future healing.
And the cardinal sin of duct preparation.
Strictly avoiding any form of thermal injury, you must use sharp dissection or, non-thermal scissors to make the final cut. Applying cautery right at the duct edge causes local tissue death and guarantees an ischemic suture line. You're violating one of Bloomgart's core principles right out of the gate.
Okay, but what happens when the ducts are inherently narrow? You can't connect the jejunum, which is relatively large, to a tiny 3 millimeter duct without creating instant flow resistance. How do surgeons increase the diameter of that ductotomy?
This leads to some crucial technical decision points for narrow ducts. For ducts that are smaller than 5 millimeters, the surgeon might perform a transverse ductotomy. So instead of simply cutting the duct straight across, which results in a circular opening, you make a slight vertical incision into the duct wall.
You essentially turn the circular opening into a slightly elliptical one, using that vertical slice to increase the overall circumference.
Precisely. It allows the duct edges to open wider laterally, maximizing the surface area available for the circumferential suture line. This minor geometric change can make the difference between a successful wide anastomosis and a constricted one.
And for the most challenging scenario, a very narrow duct, maybe 3 or 4 millimeters, what's the ultimate move to maximize the lumen size?
For that, you need the Heineke-Mikulich ductoplasty. This is a classic plastic surgical principle applied to the duct. Imagine cutting a hot dog bun lengthwise down the middle. If you then take the two ends of that longitudinal cut and sew them together in a specific transverse fashion, you convert the long slit into a much wider circular stoma.
That is a phenomenal visual analogy. You're essentially converting a linear incision into an elliptical opening just by shifting the axis of closure.
Exactly. It's all about achieving the maximal lumen size possible to minimize the long-term risk of stricture formation, which is the primary failure mode of this operation.
Now for the other side of the connection, the jejunal limb construction, the Roux-en-Y. What are the key measurements here?
The Roux-en-Y configuration is mandatory for isolating the anastomosis. The required length for the jejunal limb is standardized. It's typically 40 to 50 centimeters from the DJ flexure, which is the start of the jejunum. This length is non-negotiable because it ensures the jejunal limb is long enough to prevent any retrograde flow of digested food and enzymes up toward the hepatic anastomosis, which would cause chronic cholangitis.
Okay, so 40 to 50 centimeters is the protective distance. What path does the limb usually take to reach the liver?
The retrocolic approach, passing the limb behind the transverse colon, is universally preferred. It provides the most direct, straight, and tension-free pathway to the high hilar anastomosis.
And this brings us back to the mantra we mentioned earlier, the one that governs everything from dissection to limb selection. Tension is the enemy of HJ.
It cannot be overstated. The surgeon has to verify two things before starting the suture work. First, the limb must be completely free of twist or rotation, no axial torsion. Second, the mesentery must be long and adequate to ensure that the jejunal edge reaches the hepatic duct opening without any pulling whatsoever. If the patient coughs, if the table moves, that anastomosis must remain relaxed. Tension compromises the blood supply to the jejunal edge, tears the delicate sutures, and guarantees an early leak or a late stricture.
So with both the wide, healthy duct and the tension-free Roux limb prepared, we can discuss the actual connection strategy. Let's talk layering and suturing material.
We prioritize biological healing over mechanical strength. Therefore, the single layer, end-to-side mucosa-to-mucosa anastomosis is the gold standard. It minimizes the amount of foreign material and the ischemic footprint. A double layer closure, where an outer serosal layer is added, is generally avoided. It can restrict the blood supply to the already delicate jejunal mucosa edge.
And the choice of suture, interrupted versus running.
This is a point of absolute dogma for most HPB specialists. Interrupted sutures are the default choice. We use fine absorbable material like 50 or 60 PDS, or sometimes non-absorbable Prolene. The critical advantage is precision. Each stitch is an independent unit.
So why is running the suture, which is faster, so dangerous here?
A running or continuous suture risks the deadly outcome known as purse stringing. If you pull a continuous suture even slightly too tight, it acts like a drawstring on a bag. It constricts the entire anastomosis circumferentially. This constriction is a direct pathway to late stricture formation. Interrupted sutures prevent this global constriction. If one stitch is too tight, it only affects a tiny area, not the entire perimeter.
Finally, let's revisit the question of stenting. If the duct is very small or the tissue quality is poor, shouldn't we put a tube in there to act as a scaffold?
It seems intuitive, doesn't it? But the consensus is clear. Routine stenting is not recommended. Stents are foreign bodies. Over time, they act as a magnet and a mechanical surface for bile salts and proteins to precipitate. This leads to sludge, stone formation, and chronic low-grade inflammation.
So stenting is a salvage measure, not standard practice.
Exactly. Stents are only used selectively if the surgeon feels the tissue quality is critically poor, if the duct is microscopically small, or when performing a challenging reconstruction where a temporary scaffold is deemed essential. And even then, it has to be a small, soft, internal tube, like a 5 French infant feeding tube, and it must be monitored closely for complications.
Okay, here is where we delve into the heart of the technical artistry. The component of this operation that truly sets the standard for micro-precision. We're talking about the concept of extracorporeal knot tying, sometimes called the parachuting technique. This is the aha moment for the learner, so we need to understand it in intimate detail.
This technique is what separates the functional repair from the failed repair. It seems paradoxical, but the surgeon is placing the sutures through the duct and the jejunum. But the critical requirement is that the knot itself is tied outside the lumen. It must be tied extracorporeally.
Why go through this complex, counterintuitive process? Why can't the surgeon simply tie the knot as the stitch is placed, which would land the knot inside the flow path?
We need to understand the physics of bile flow in foreign bodies. The problem with interluminal knots is that the knot mass, even a tiny 5-0 suture knot, becomes a persistent foreign body exposed to bile. Bile is a detergent, a complex mix of salts and proteins. That knot acts as a nucleation point, a tiny eddy, where bile sludge accumulates and calcifies, eventually forming stones.
It's like a barnacle anchor. The minute interruption in the flow creates a starting point for a stone.
Precisely. That chronic physical and chemical irritation promotes inflammation, which leads directly to scarring and stricture formation months or even years later. The goal is to make the internal surface of the anastomosis perfectly smooth, a physiological tunnel. And that means excluding all foreign material, especially the knot mass, from the lumen.
That makes perfect sense. But for a surgeon just learning this, tying knots outside the lumen of a tiny, deep duct sounds like a massive recipe for tangled stitches and frustration. How high is the learning curve for this exact technique?
The learning curve is substantial. It requires exceptional fine motor skill and spatial awareness in a deep, confined space. The surgeon has to visualize the final outcome before placing the first stitch. You must have discipline. This technique is classically advocated by established surgical authorities like Blumgart and Mengert.
Okay, let's break down the mechanics. Let's focus on the posterior wall, which is often the most challenging due to depth. Walk us through the exact sequence of the parachuting technique.
Right. The process starts by placing the stitches sequentially. You will need about 15 to 20 interrupted sutures for the posterior wall, depending on the duct diameter.
Describe the precise needle pass for a single suture.
For each interrupted suture, the needle passes in a defined trajectory. You start on the jejunal side, passing the needle from the mucosa to the seromuscular layer out through the raw edge of the jejunum. You then pass it through the bile duct wall, making sure you catch the mucosa and the full thickness of the duct wall, and exiting through the outer layer.
So the needle has traversed both walls, and the two ends of the suture thread are now just hanging free in the field.
Yes. And here is the crucial step. All sutures for the posterior wall are placed, but they are absolutely not tied. They are kept along, organized, and often color-coded or sequentially clamped outside the field. This can create a delicate forest of 15 threads.
Wait a second. So you're intentionally leaving 15 fine 5 or 6-0 stitches untied in delicate high-stakes tissue. Doesn't that risk them getting tangled or pulled out or misplaced, especially with the breathing movement of the patient?
That is the risk, and it must be managed by supreme discipline and team coordination. The surgeon and the assistant have to ensure absolute minimal manipulation of the jejunal limb during this placement phase, but the reward, the ability to inspect all 15 points before approximation, is worth that risk.
Okay, so once all 15 stitches are placed and untied, how do you bring the jejunal limb to meet the hepatic duct?
This is the parachuting movement. You use the untied sutures as guide ropes. The jejunal limb is gently advanced, or parachuted, down the length of the untied threads toward the hepatic duct opening. The threads, which are under minimal tension, guide the jejunal lumen precisely to the hepatic duct lumen.
And the moment the jejunal limb is seated against the duct, how is the knot secured outside the lumen?
Once it's seated, the surgeon begins tying the knots sequentially, starting in the middle and working laterally. Because of the initial needle pass from jejunal mucosa to hepatic adventitia, when the knot is tied, It naturally retracts and seats itself on the serosal surface of the jejunum and the adventitial surface of the bile duct. Critically, it lands outside the flow path, excluded from both the biliary and jejunal lumens.
That is the truly ingenious part of the surgical geometry. You've achieved perfect mechanical alignment using the stitch, but the mass of the knot is intentionally relegated to the non-fluid side of the connection.
That is the essence of extracorporeal knot tying in this context, and the benefits are profound. It ensures there is absolutely no foreign body acting as a nidus for stones inside the bile duct. And because you tied each stitch independently after approximating the two surfaces, you prevent any localized purse stringing or narrowing that would happen if you tied each one aggressively as you placed it. This guarantees the widest possible lumen.
This level of detail confirms that HJ is indeed an art form driven by foundational surgical principles.
It is the ultimate display of surgical mastery over anatomy and material science. You then repeat this entire meticulous process for the anterior wall, maintaining all the same principles. Perfect alignment, tension-free, and every single knot secured extracorporeally.
The posterior and anterior walls are constructed, the knots are tied, and the anastomosis looks pristine. But as we know, the operation isn't over until the final safety checklist is completed. Let's start with the discipline required for contamination control.
In high-risk HPB surgery, maintaining sterility and minimizing sepsis is paramount. Bile is almost always septic, especially if the ducts were obstructed preoperatively. The imperative in the operating room is absolute. Prevent bile spillage during duct handling.
But if, despite all precautions, bile spillage occurs, because surgical realities sometimes dictate, what is the mandatory non-negotiable response for the surgical team?
The response has to be immediate and disciplined. First, copious saline lavage of the entire surgical field to wash away the corrosive and septic bile. Second, the entire team must perform an immediate change of gloves, and all instruments that touch the bile must be isolated or exchanged. And third, the antibiotic prophylaxis regimen must be reviewed and potentially reinforced postoperatively, anticipating that increased contamination risk.
That's the contamination response. Now we get to the final inspection, the moment of truth before the team moves on to closure. What must the surgeon confirm regarding the anastomosis integrity?
This is the critical review. Before anything is closed, the surgeon must systematically confirm 4 things. 1. Patency and hemostasis. Has all bleeding stopped? Is there absolutely no visible bile leak? Sometimes this requires gently injecting saline into the duct proximally to confirm the seal. 2. Vascularity. The anastomosis must be wide, pink, and well vascularized. If the jejunal or hepatic edge looks pale, bluish, or bruised, it is ischemic. A revision must be considered instantly or failure is imminent. 3. Geometry. There must be absolute confirmation of no tension, compression, or kinking of the jejunal limb, especially where it passes behind the colon. The path has to be smooth. And 4. Size. The anastomosis must be demonstrably wide, at least the width of a small finger, ensuring low resistance to bile flow.
With those safety checks complete, let's talk about drain placement. After such a high-risk connection, does the surgeon automatically leave a drainage tube in place?
Drain placement is selective, not mandatory. In cases of uncertain hemostasis, very high-risk reoperations, or if the surgeon feels the need to monitor for an immediate leak, a drain is justified. But if it is used, there's a strict rule. The drain must be placed near the anastomosis, but explicitly not touching it.
Why the restriction against touching the suture line?
A plastic drain tube, even a soft one, rubbing against a fresh, delicate suture line can cause mechanical erosion over 24 to 48 hours. This is a recognized cause of postoperative anastomotic breakdown or an intracutaneous fistula. It must sit nearby to monitor for fluid, but not abrade the repair.
Looking ahead, postoperatively, what is the team bracing for in the immediate recovery phase?
The primary anticipation is the detection of a bile leak, which, due to the inflammatory response and eventual suture breakdown, typically presents around day 3 to day 5 post-surgery. Vigilance for signs of cholangitis fever, pain, jaundice is also critical. Long-term, the patient enters a surveillance period for the silent enemy, stricture formation.
This entire detailed approach, the meticulous attention to viability, geometry, and the exclusion of foreign bodies, seems encapsulated in that powerful, almost spiritual mantra of the HPB surgeon.
It is the distillation of all the lessons learned from historical failures. The core mantra is simple, yet it encompasses everything. Wide duct, healthy mucosa, no tension, no ischemia, no knots in lumen.
And the darker, more poetic truth that follows the patient into the recovery room. The liver remembers your sutures, meaning any technical flaw, no matter how small, will eventually manifest as a complication. You can't hide technical deficiency in this field.
You absolutely cannot. The biological environment of the biliary system, high pressure, caustic fluid, perpetual risk of infection, it magnifies every single technical error over time.
We've gone through the entire master script. For the learner, rather than simply repeating the checklist, let's quickly connect the dots. Let's show how each strategic decision flows into the next to achieve that long-term patency.
That's a great idea. Think of it as linking the steps. Preoperative assessment. We start by confirming the anticipation of bile duct size and condition from imaging. This directly informs the decision on whether to plan for a ductoplasty.
Which leads to anatomical confirmation. You identify the LHD as the preferred target because you know its geometry allows for the widest ductotomy, and you protect the ARHA because compromising it guarantees ischemia.
Precisely. That width is then maximized during duct preparation by trimming to healthy mucosa and employing a transverse ductotomy or Heineke-Mikulitz ductoplasty if it's necessary.
Which flows seamlessly into the jejunal limb preparation. You must ensure the roux limb is the adequate length, 40-50 centimeter, and critically has sufficient mesenteric length to guarantee no tension. Tension defeats all prior efforts.
And the final link is the anastomotic strategy. We choose the single-layer interrupted sutures over running to avoid constriction or purse stringing. And we prioritize the extraluminal knot position to eliminate the knot mass as a nidus for stones in the bile flow.
This comprehensive interlocking strategy is why modern HJ is so successful compared to its historical predecessors. Every step protects against the three key failure modes: stricture, leak, and cholangitis. This has been a fascinating and incredibly detailed deep dive into a procedure that demands the highest degree of anatomical knowledge, technical dexterity, and surgical discipline.
The high-yield messages for you, the learner, must be action-oriented and clear. Always. No left duct anatomy because it's the superior target. Respect the aberrant RHA as a constant hidden threat to viability. Prefer interrupted sutures for perfect, tension-free alignment. Keep knots outside the lumen to avoid stone formation, and perpetually maniacally avoid tension and ischemia.
Fantastic. Before we close, we spent all this time focusing on surgical perfection. But let's leave the listener with a provocative thought, building on the fact that even a perfectly executed repair can fail over time, sometimes years later. Considering that this highly delicate repair is uniquely susceptible to late stricture formation, what subtle, non-surgical patient factors like certain systemic inflammatory conditions, or perhaps even specific nutritional deficiencies that compromise tissue remodeling and collagen formation, might predispose the patient to long-term failure, even when the surgical technique was flawless? What is the role of the patient's underlying biological environment in making or breaking the surgical success? Something for you to mull over as we consider the holistic patient journey and long-term surveillance.
That is the critical next frontier of understanding. Surgical success is only half the battle. Biological healing is the other.
Before we wrap, we have two mandatory declarations to include. First, I would like to acknowledge and express my deepest gratitude to Mr. Nilesh Lothaji, a respected teacher, philanthropist, and businessman from Chennai, India, whose guidance and mentorship have been invaluable.
And finally, we must clarify the academic framework for this specific material. The editor and author of this specific script is Dr. Santhal Kumaran, and his role is strictly limited to editorial organization, academic narration, and experience-based commentary derived from his high-volume practice. We must be clear. We claim no ownership of the original surgical techniques discussed, such as the Roux-en-Y principle or the Bloomgart tenets, which belong to the broader historical surgical community.
Thank you for joining us on this deep dive into the art and science of the hepaticojejuostomy. We'll see you next time.